Hello, class. I am recording the lecture that I haven't had a chance to finish with you guys and posting it on Canvas for two reasons. One, as an example of how I would like you to do your case studies. So you notice I have my PowerPoint up. You can't see my face, but you can hear my voice. And number two is I have to go to a meeting on Thursday, so I won't be able to meet with you. So I'm going to review the information that I had already presented and finish the rest of the PowerPoint. So if you remember, we started by talking about epigenetic regulation. Your environment plays a huge role in which genes will be upregulated that may be good or may be bad for the purpose of inducing inflammatory responses or oxidative stress or controlling them that may or may not cause atherosclerosis. So here what we can see on the left-hand side, close to the bottom, are the histones, which are the green ovals, and the blue lines around the histones represent DNA. And when there is close association between this histone and DNA, there is going to be less transcription of a respective gene. When we talk about epigenetic regulation, it means that either the DNA or the histones, the combination of the two is called chromatin, are being modified by adding a methyl group, for example, or acetyl group or a phosphoryl group that will change how tightly the DNA is associated with the histone. The less tight the association is, the more likely transcription factors will be able to bind to promoters of genes and increase transcription. So when we're looking at methylation, DNA methylation, some of you have read in the other PowerPoint that if there's an increased methylation in respective genes on the DNA, specifically the cytosine, as you can see in the upper right-hand corner, there is going to be less gene transcription because that methylation of that cytosine inhibits transcriptional activators from being able to bind to the promoters. On the other hand, as we've talked about with cancer, if there is less methylation of the cytosines in the promoters of certain genes, there will be a lot more transcription of those respective genes. The problem is figuring out which genes are going to have an increased association with histones or decreased association with histones with respective environmental stimuli, and the same thing for methylation of DNA. That's something we're still trying to work out. So, for example, if we eat blueberries, we might see an increased transcription of a gene that is anti-inflammatory or antioxidative stress, but a decrease in transcription of the pro-inflammatory genes. So what's in between that regulates the modification of histones or gene promoters upon a particular stimuli? We still don't know. We are still working that out. But very importantly, as we said in class, it's necessary to understand that genes will be transcribed into messenger RNA, which will then be translated into a protein. And proteins are your enzymes, your receptors, signaling molecules, etc., that play a role in maintaining cellular health. And they all have a genetic code. Many people think that their diseases like coronary artery disease or cancer, things of that nature, are genetic. When they use that term, there's an implication that there is a gene mutation. One of the nucleotides, like a C or a G or a T or an A, has been changed to something different. And therefore, when that gene is transcribed, it doesn't translate into a healthy, normally active, or normally folded protein. That's what gives disease. So that's a mutation. That's genetic. Epigenetic means that we're increasing or decreasing the transcription of a respective gene because we are increasing or decreasing its association with a histone or methylating or demethylating cytosines in its respective promoter. Now, there's a lot more to it than this, of course, but we can reverse epigenetic marks over time if we modify our environmental stimuli. We cannot reverse a gene mutation. So this is really important to be able to communicate to your patients when we're talking about nutrition or other things they might be exposed to that may increase or decrease good or bad genes. So we started by talking about an inflammatory environment as well as hyperinsulinemia, because we will see a similar effect in endothelium. In the presence of a pro-inflammatory response, we will always have this wonderful molecule, peptide, TNF-alpha, available to activate its respective inflammatory and proliferatory pathways. So when that TNF-alpha binds to the TNF-alpha receptor, as you can see here on the endothelium, the endothelial cells, it initiates the pathways that many of you have already talked about in regards to controlling them through your food intake, eventually resulting in NF-κB, which is a pro-inflammatory transcription factor binding to the promoters of genes that facilitate monocyte binding to endothelium. And here we can see VCAM1 being increased at the transcriptional level, which would then be translated into a receptor protein that moves to the surface of the endothelium. At the same time, if you look at that black monocyte up there, it is increasing the transcription of a receptor called VLA4, which really likes VCAM1, so they associate. At the same time, we're increasing the transcription of some other genes, MCP1, CCR2, which are chemokines. A chemokine means it likes to recruit other cells, particularly here, white blood cells. And that's going to help facilitate the movement of the monocyte into the intimal layer of an atherosclerotic vessel. When that monocyte gets in there, it's really interesting. We talked a little bit about stem cells and progenitor cells last week, and what that simply means is that a gene will be regulated in a particular way to present itself as a phenotype. Here we are changing from a monocyte to a macrophage because the promoters of certain genes that will give the phenotype of a macrophage instead of simply a monocyte are being upregulated. So we've changed from one cell type to another cell type. Now, when this macrophage is activated, it is going to increase the expression of what we call scavenger receptors, and those are what I drew there as little L's. In the meantime, this inflammatory process, which is always correlated with oxidative stress also, is resulting in high levels of oxidized LDL. Now, these scavenger receptors on the macrophage really like to associate with oxidized LDL. They do that, and it goes through a process similar to what we talked about at the endothelial layer, in which the oxidized LDL is taken up by the macrophage, and now it turns into what we call a foam cell, which is our main hallmark of atherosclerosis. If you were to look at these under a microscope, you can see little fat droplets in them. And so if we look at an atherosclerotic vessel, you can see this presentation of what looks like fat, which people will call plaque, but it's really due to this increased amount of foam cell availability and calcium and a lot of other things too. But keep in mind that this lesion does have blood vessels on its surface that are directly in contact with blood flow, and in the presence of hypertension, inflammatory responses, increased abnormal shear stress, those blood vessels can rupture, causing a bleed, which obviously will develop into a thrombus, which is the number one reason people actually have a myocardial infarction. Okay, so a couple of examples, which most of you have talked about a lot. At the bottom, the NF-κB transcription factor. A couple examples of gene regulation, increasing or decreasing the inflammatory response that predisposes monocyte binding to the endothelium. At the top, if you guys remember, I talked about BCL6, which is the B cell lymphoma 6 protein. It's an oncogene, which means that if it is not regulated properly, remember we talked about transposiums in class, then it could result in an increase in proliferation and differentiation of lymph cells. That's lymphoma. But in this particular scenario, assuming that it's regulated properly, when it is increased, it will actually bind to the promoter of our VCAM1, which we saw in the previous slide, and MCP1, which we also saw in the previous slide, to inhibit their transcription. So BCL6 is an transcriptional inhibitor. On the bottom, however, if we increase NFKB transcription and expression, it binds to the promoters of VCAM1 and MCP1 to increase their transcription. It's a transcriptional activator, ultimately leading to our monocyte adhesion and thus intimal migration, giving us our classic atherosclerotic look. Now, I put this slide in here because it demonstrates the second hallmark of atherosclerosis, which we've talked about in detail with our food stories. But I like to talk about hyperinsulinemia because a lot of people don't realize that diabetes, type 1, type 2, if you have too much insulin, it actually will bind to receptors on the endothelium, facilitating many different processes. There's a couple of them shown here that ultimately result in smooth muscle cell proliferation and differentiation into that synthetic phenotype we talked about. So smooth muscle cells should be pretty responsive to biochemicals that are trying to auto-regulate blood flow to respective tissue. Well, when these smooth muscle cells undergo differentiation into what we'll call the synthetic phenotype, they don't respond well. So they may not be able to relax, vasodilate the tissue blood vessels to allow more blood flow. They'll be tighter. They don't respond as well. They're also experiencing a different morphological change, which means that they're going to be thicker and malformed. This is going to cause the blood vessel to ultimately be thicker and less compliant. And when we're talking about blood vessels, it's really important to be able to differentiate the terms compliance and elasticity. Remember, we talked about pulse wave velocity a little bit. Make sure you don't forget about that. So when we're talking about compliance, it means that the blood vessel is able to expand and accept volume, just like when we're talking about lung compliance. Elasticity simply means that once that blood vessel has expanded to accept volume, it has the ability to go back to its resting state. So when we're talking about the aorta, it has to be able to have good elastic recoil, because when it accepts that volume coming out of the left ventricle, it's got to be able to recoil back, pushing that blood forward, maintaining that forward propagation, that forward flow, that pulse wave velocity that gives good peripheral perfusion. So this is basically showing that hyperinsulinemia will increase the amount of insulin binding to the insulin receptors, recruiting these pathways that play a role in inflammation. You can see over here VCAM1, and smooth muscle cell proliferation and differentiation. So we have two hallmarks of atherosclerosis: foam cell and smooth muscle cell proliferation and differentiation. And the thing about the differentiation part is once that occurs, or as it's occurring, those smooth muscle cells actually begin to migrate where they're not supposed to be. So they'll wind up closer to the intimal layer than where they're supposed to be. And this is a paper actually that I did with my husband. That's Brendan Gongol up there. I talked a little bit about this. And the uniqueness of this paper is that we wanted to see if we could use a different drug than statins, we've talked about statins a little bit, as an anti-inflammatory drug to reduce monocyte binding to endothelium. So you don't really have to pay attention to the siRNA stuff on the left side, but what I like to look at is the control on the top and the metformin, which is the third column down. What you can see is when we treat the cells, these are endothelial cells, with metformin, you see less green spots in the top row relative to the control, and in the top row relative to the metformin plus compound C, that's an inhibitor of my favorite gene, which happens to be AMPK over here. And we'll talk more about that later. So we actually were able to show that when we treat animals and cells with metformin, we are activating pathways that increase the amount of BCL6, which you can see down in the left-hand corner. siRNA simply means that we knocked it down, that gene's not available. You can see there's a whole bunch of green there, meaning that there's a lot of monocyte binding. When we knocked down BCL6, we silenced it. It's not present. It can't act as a transcriptional repressor for VCAM1, for example, anymore. Then there's a whole bunch of monocyte binding. When we treat with metformin, that monocyte binding goes down. That's why there's less green dots. And it seems that metformin acts through BCL6, because you can see that in the metformin column, if we look at BCL6 siRNA, there's a whole bunch of green. That means that in order for metformin to work as an anti-inflammatory drug to reduce monocyte binding, BCL6 must be present. So this is one of the really cool stories that we were able to put out. Now metformin is being used in human trials in China right now. So who knows, maybe in 10 years we might change from statins, which we've talked about decreased myelin sheath integrity in the brain, to metformin. All right, so this is a slide that represents the paper coming from Biochemica, Epigenetics and Atherosclerosis. And at the top here, you can see the acronym DNMT1. It stands for DNA methyltransferase. I've actually worked with this gene also, and I'll show you some pictures about that a little bit later. So DNA methyltransferase 1, DNMT1, actually takes methyl groups off of the cytosine, which means that that should increase transcription of the genes that it's doing that to. And here, if you look on the left side, when we talk about smooth muscle cells, you can see that in the presence of atherosclerosis, there is actually an increase in DNMT1 expression at the promoters of genes that are important for smooth muscle cell proliferation. So in this particular scenario, DNMT1 is kind of the bad guy because it's increasing the transcription of smooth muscle cells, and we don't need too many of them in the blood vessel because it gets too thick. At the top of that, on the left-hand side, you can see it says estrogen inhibits smooth muscle cell proliferation. You can see that it is pointing to a phrase that says hypermethylation of the estrogen receptor alpha and estrogen receptor beta. So what this would mean is that the estrogen receptor is not going to be transcribed that much because estrogen is inhibiting the methylation, or estrogen is allowing the methylation to maintain a high state. So that came out kind of strange. So what that means is that there is more methylation of the promoter. Okay. If we look down towards the bottom left and talks about monocyte and macrophages, it's talking about LPL, increasing foam cell formation. And it's also talking about different mechanisms by which foam cells, or the inflammatory process that changes monocytes to macrophages to foam cells, are being activated. So read through this article and just get a good idea of what epigenetics means and how it plays a role in increasing or decreasing genes that might be important for developing or inhibiting atherosclerosis. Okay, this is another paper that I worked on with one of my colleagues, Han, and also my husband. You can see his name up there somewhere. It should be in there anyway. Brendan Gongol, there he is. This is a story about inflammation causing atherosclerosis. So the diagram is showing that when blood vessels are exposed to what we call atheroprone flow, which means oscillatory flow, not good forward pulsatile flow, there's going to be an activation of a transcription factor called SREB2. And what that's going to do is increase the expression of NLRP3. Now, that is a component of the inflammasome, and we talked about the inflammasome before. It's a group of proteins that work together to facilitate pretty much all inflammatory processes that are not healthy. You also see that it increases the transcription of NOX2, and one of the girls talked about NOX2 as increasing ROS. So here, when blood vessels are exposed to oscillatory flow, which commonly occurs in the bifurcations or the aorta, then there's going to be an increase in inflammatory responses through the inflammasome and an increase in oxidative stress through ROS production. Now, how do we deal with this? Because everybody gets atherosclerosis in those particular areas, but some people get more than others. Well, if you have a basal level of inflammation that is higher than your friends, then you're more prone to atherosclerosis for the reasons that we've already talked about. But what we have found is that if you exercise moderately, that means walking every day or running, not too fast, 10 to 20 minutes a day, then for that period of time, you actually will activate genes that are protective against this. So I talked about AMPK just slightly in a couple slides ago, and I'll touch on that a little bit more later. But when you exercise, you activate AMPK. That is protective against atherosclerosis for many different reasons. On the bottom part of this, you can see figure A and figure B, and a picture of a mouse, well, a few mice, 4 mice, aortas. You can see the aortic arch, which is the curvature at the top, and then the ascending aorta, which is straight. And when we fed these animals, don't worry about the labeling at the top, but when we fed these animals an atherogenic diet, and what that meant was it wasn't just high cholesterol, it was high bad cholesterol, and it was synthetic. You can see that there's a lot more atherosclerotic lesion that formed there. Now, in the right side, you can see that we labeled SREBP2 on the top of the, we'll say second column, groups of aortas. That means that we got rid of that gene in the animal. It's knocked out. Under normal food, if SRBB2 is knocked out, it seems that we have less atherosclerotic lesion. So SRBP2, if it's not present, is going to reduce the amount of NLRP transcribed, the amount of NOX2 transcribed, and they will work together, these two, to increase the amount of ROS and inflammation. When SRB is not present, this reaction cannot occur, and therefore it's protective against atherosclerosis. Okay, now I want to move on to something slightly different, and a couple of the students touched on this a bit, but I want to talk about oxidative stress and mitochondrial function. And those of you that are interested in the hypertrophies, you want to think about this in regards to the development of hypertrophies due to ventricular remodeling. Okay, so if we look at the colored picture here, it starts by, it starts our flow diagram with hyperglycemia. Now, a lot of people don't really understand diabetes. They think, well, if your blood sugar is 300, 400, 700, then you're potentially going to have problems because you'll go into a coma because your blood sugar is high. That actually has nothing to do with it. When people are hyperglycemic, it simply means that their insulin receptors are not working well, and therefore the glucose is not getting into the cell. The reason why they develop an acidosis is because they're working off of fats and proteins being metabolized for energy. We call it ketosis. So the reason why they go into a coma is because of a severe acidosis. It's not because their sugar levels are high. It's because their cells are ultimately starving. Okay. But we know that people with chronic hyperglycemia are more likely to develop atherosclerosis. Well, one of those reasons is because they also are typically hyperinsulinemic, and we talked about that a minute ago. But the second reason is that this hyperglycemia is potentially assuming that we have working insulin receptors, okay, is getting into the cell and essentially causing a glucose overload in the mitochondria. So remember we talked about food, and when we eat too much food, we actually can cause oxidative stress, which can lead to fibrosis of tissue. Well, one of the reasons for that is because we are making the mitochondria work harder to try and handle that food load, that glucose load. And when it works harder, it gets sick, and it's going to increase the amount of reactive oxygen species. So if you look at the mitochondrion kind of in the middle, you can see O2 negative, our reactive molecule, which a couple of the girls had talked about. And you can see when that is increased and it comes out of the mitochondria, it actually plays a role in breaking DNA. It plays a role in inhibiting some of our protective mechanisms like eNOS. We talked about that a little bit. It increases other pathways of oxidative stress. You can see age here. So I encourage you to look up age so that you know what that means. It activates some of the pathways that are responsible for increasing NFKB transcription. And of course, you can see in the bottom right-hand side, when we increase NFKB transcription, we've got an increase of those genes that play a role in increasing the thrombotic environment, which is your PAI1, increasing cell proliferation and differentiation, which is your TGF beta 1, and then increasing monocyte binding, which is your VCAM1 and your MCP1. So high glucose load, assuming that your insulin receptors are still working well and it's actually getting into the cell, can cause tissue damage because it's working the mitochondria too much. One of the byproducts of mitochondrial function is these radical oxygen species. And when we have an increase in those radical oxygen species, you've got activation of all of these oxidative and pro-inflammatory pathways. So your mitochondria are really, really important. Okay, and if you look up in the upper right-hand corner, talks about oxidized LDL, free fatty acids, hyperglycemia, benzopyrene, and other things like fatty liver will increase the amount of ROS produced by the mitochondria, which is going to cause mitochondrial damage. Now keep in mind that the mitochondria has its own genome. So when you have a cell, you've got a nucleus, which has the genome that transcribes genes for the whole body and everything that is important for its function and homeostasis. But the mitochondria, lacking a nucleus, but has its own DNA, very much like bacteria. So it doesn't really matter if you believe in creation or evolution or whatever, but the fact of the matter is that the mitochondria is very, very similar, if not almost exactly the same as a bacteria. Very interesting, a prokaryotic cell. Just something to think about. Wonder how that happened or what the purpose of that was. Anyway, so we go back up to this figure, mitochondrial damage, mtDNA, that's mitochondria, DNA damage occurs. Mitochondrial dysfunction occurs. This is going to produce aberrant ROS levels because it's overworking and it's sick. This is going to cause endothelial apoptosis when it's not necessary. Remember, there needs to be balance. It's going to cause vascular smooth muscle cell hyperplasia. It's going to decrease the aerobic capacity of the endothelium and the smooth muscle cells. That means it's not going to be as efficient. It's more prone now to even more oxidative stress. All of this is essentially going to increase the probability of the development of atherosclerosis. So this is a picture that demonstrates some of the work we did with our gene AMPK, and AMPK stands for AMP activated protein kinase. So if you remember, we talked about ATP as being a major energy source. When the terminal phosphate of ATP is cleaved, that gives energy. When that's taken off, that leaves ADP, D meaning di. And then when the adenosine is left with only one phosphate, that stands for AMP, monophosphate. Well, when there's a lot of AMP available in the cell, AMPK will be activated. It's an energy regulator and an energy sensor. It's also a stress sensor. So what we found in one of our studies, and hopefully we'll get this published in the next couple months, is that when we activate AMPK, and we did use metformin in this study, I just didn't show it here because the pictures are not as easily seen. When we treat the cells with AMPK activators like ICAR or metformin, we can actually see an increase in mitochondrial membrane potential. That means that there's more energy being produced. That means the mitochondria is functioning normally or really well. And the way we're able to see that is if you look at the column, or I'll say the row that is labeled with ICAR, the very first picture is really red. The second picture is green. And then the third picture is yellow. So we actually stained the cells with a dye that specifically will change the color of the proteins on the mitochondrial membrane when it is activated. And then we merge those together. The more yellow we have, the more mitochondrial activity membrane potential we have. Now this is good because if you don't have good mitochondrial function, it means that we're producing a lot of ROS. So our goal with this was to be able to see if we could actually use AMPK activators. ICAR is our control because we always know that activates AMPK, but also metformin to see if we can increase mitochondrial health, and it worked. Now what we were also working on is the epigenetic regulation of the genes important for mitochondrial membrane function, and those are called UCP genes, uncoupler proteins. So look up uncoupler proteins. That will help you understand mitochondrial membrane potential. Now remember, DNMT1 is an enzyme that takes methyl groups off of promoters. If we're taking the methyl groups off of the promoters, then we will have an increase in transcription of those respective genes. Well, we wanted to see if AMPK, it's a kinase, that means it phosphorylates things. When AMPK phosphorylates DNMT1 to inhibit it, will it stop taking those methyl groups off of will it stop putting those methyl groups on the promoter? So I need to repeat that because I messed it up a little bit. So DNMT1, DNA methyltransferase, puts methyl groups on the promoters to decrease their transcription. We wanted to say that AMPK would phosphorylate DNMT1 to inhibit it from doing that, meaning that the promoters then would have less methyl groups and would be transcribed. We looked at the genes specific for mitochondrial membrane potential function, like the UCPs, and mitochondrial biogenesis. Okay, and what you see up there when it says DNMT1 S730 and DNMT1 S730A, we actually cloned that gene and mutated the serine that AMPK would phosphorylate to an alanine, so that's why you see S730A on the right side. When there's an alanine there, AMPK cannot phosphorylate it. So we mutated DNMT1 and we lost that effect. So if you see the very right column, when we're merging those two pictures together, we have a little bit of yellow, not as much when we had the DNMT serine 730. So this implies that when we activate AMPK, it phosphorylates DNMT1 to inhibit it from methylating the promoters of the genes important for mitochondrial membrane potential. When we mutate that gene, we don't get the same effect. These are really, really hard experiments to do. They took us really 5 years to get this worked out. Now, the bottom 4 pictures, the black and white ones, are of mitochondrial biogenesis. So we stained the cells that will specifically show or allow us to quantify mitochondria. And you can see that when we treated the cells with ICAR, our AMPK activator, and then we see the same thing with metformin, it's just not shown here, that there's more white. The more white means that there's more mitochondria. So not only are we increasing the function of mitochondria, we're also increasing the amount of mitochondria available by activating AMPK, which inhibits DNMT1 from methylating promoters, which will allow the transcription of genes important for mitochondrial function and biogenesis. Okay, now, why is this important? Because you guys are probably thinking, well, we don't care about this, we don't know anything about this, what is AMPK? AMPK is a really important molecule that can be activated with calorie restriction by certain foods like grapes, wine, yay, and exercise, and a lot of other things too. So when we're talking about exercise, when we're talking about what we eat, we could really be increasing AMPK, inhibiting DNMT1 methylation of genes that are important for health, homeostasis, like mitochondria. That's not hard to do. You eat grapes and you exercise, and some other stuff too. And don't eat too much, because if you eat too much, you'll have a whole lot of ATP, and what does that do to AMPK? It inhibits it, because it's activated by AMP. Okay, so now I want to talk a little bit about some clinical stuff, now that we got some of the molecular stuff out of the way. I know this paper is old. It's a 2004 paper, and I don't typically like to look at these papers except when they have some significant relevance to us. So the name of this paper is Inflammation as a Cause of Malnutrition, Atherosclerotic Cardiovascular Disease, and Poor Outcome in a Hemodialysis Patient. This study was done on people that did not start with atherosclerosis, but they had renal failure, and therefore they needed dialysis. They have to keep in mind what dialysis is. There's tubing involved. And not only can the tubing not be clean and therefore be pro-infective, pro-inflammatory, it also is made of synthetic material that can, I don't want to say degrade, but can leak into the bloodstream. Okay, very similar to things like water bottles. You hear stories about that. Don't microwave your food in a plastic container. The glue that holds material together in your couch, for example, does a similar thing. So there's a lot of environmental, I don't like the word toxin, but a lot of environmental chemicals that actually produce an increased inflammatory oxidative stress environment in your body that we don't even think about all the time. So if we look at this table 1, potential causes of inflammation in hemodialysis patient. Non-hemodialysis factors, reduced renal clearance of cytokines, that makes sense. Accumulation of uremic toxins such as advanced glycation in products. So in the previous slide of mitochondrial function, I said you should look up age. Well, this is what age is, advanced glycan end products that stimulate the synthesis of cytokines. Chronic heart failure. Okay. The atherosclerotic process per se can be caused by persistent infections, and I'll talk a little bit about that in, I think, the next slide. And of course, there's always genetic factors. I'm sure at this point, though, when they used genetic factors, they weren't really thinking about it properly. And then hemodialysis-related factors continued over here. The catheter, the graft, the fistula infections, bioincompatibility of the dialyzer membrane, complement activation, remember the complement immune system, exposure to endotoxins and other cytokine-inducing substances, back filtration. So who would have thought that putting somebody on dialysis increases the risk for atherosclerosis independent of other factors? Okay, so those are some things that we want to think about. Table 2, shows some selected studies, demonstrates that some selected studies showed a relationship between inflammatory biomarkers and the outcome in hemodialysis patients. So you can see IL-6, we talked about that a little bit. CRP we haven't talked about yet, but it is called C-reactive protein, which is commonly used as a biomarker of inflammatory processes or disease. Procalcitonin, which is the precursor for calcitonin, and very important for calcium homeostasis. Please try not to think about calcium as just something for your bones. It is one of the most important signaling molecules in your body for everything. But when it is increased, it's a marker of sepsis or infectious inflammation. So you can see that dialysis was correlated to IL-6, CRP, procalcitonin, and fibrinogen. Most of you should know what fibrinogen is, neutrophils, and all of them had an increased mortality, most of them due to cardiovascular disease. Okay, so expanding on that, chlamydia, pneumonia. Most people think of chlamydia as being an STD. It doesn't have to be an STD. Just stereotype that we have a tendency to think about. But chlamydia and H. pylori, a lot of bacterial infections that have a tendency to be chronic because people don't get really acutely ill and therefore they're not treated promptly, can result in atherosclerosis, independent of other factors. So this picture is basically showing you the process by which chlamydia can become a latent mechanism by which inflammation can occur. It's really interesting. So here you have EB, which stands for elementary body of the chlamydia that is taken into the cell via endocytosis. Okay. And then chlamydia actually will prevent, sorry for the typo, the vesicle from fusing with a lysosome. And remember, a lysosome is important for degrading things that need to be recycled or things that need to be gotten rid of. So this phagosome maintains the elementary body of chlamydia. And over time, it will differentiate into a reticular body. Okay. The reticular body will replicate to form an inclusion body that may become latent. So it might show up later on. You're infected, you don't know it, you got a little extra stress, boom, the infection is released, or it might be minor and over time it just develops into things like cancer and atherosclerosis. Okay, so it may become latent or it may differentiate into elementary bodies and then be released by lysis of the host cell. This shows active infection, right? So the top figure kind of gives you a diagram depiction of what's going on, and then the bottom figure, B and C, actually shows you those EB and RB, I will say, vesicles, phagosomes. And this is actually an atherosclerotic plaque lesion. I can't believe I just said plaque. Okay, so here you can actually see a foam cell, an infected foam cell on the upper left-hand side, and an EB body in there. Pretty interesting. And of course you can see the fat globules, that's what FG stands for, and the nucleus of the cell. So that's a really pretty foam cell. You can see the fat globules in it, and you can see the EB bodies, so it's infected with chlamydia. The bottom figure is infected atheroma, and what they did is they stained the lesion with an antibody that is specific to chlamydia. And when we do that, we typically have a dye associated with that we can see. So you can see that on the left side, the arrow is pointing. We can read down here, staining with chlamydia pneumonia specific monoclonal antibody, and then staining with the control antibody on the right side. So on the left side, you can see that there is chlamydia in the atherosclerotic lesion. So you don't necessarily have to have a bad diet or not exercise or whatever all these stereotypes are that lead to atherosclerosis, you could actually have a chronic infection that you didn't know anything about, and boom, next thing you know, you're in the cath lab getting an angio because you have a 95% occlusion of your right coronary artery because of an infection. Okay. And this picture is demonstrating what we talked about in the first couple slides about monocyte binding to the endothelium and migrating to the intimal layer, but it adds a little bit more to it, which I think is important. So I'm going to talk about B down here so you can see that the white blood cell, the monocyte with these little red receptors, likes to bind to the endothelium and migrates in there. And in this particular scenario, if you notice, it's got EB bodies in there. That means that they had been increasing the, we'll say, activation of that white blood cell in an inflammatory nature. Those EB bodies are released from that monocyte, which is probably now a macrophage, but right here is depicted as a monocyte. And those EB bodies can actually migrate into the smooth muscle cell. So now, not only do we have these EB bodies in our monocytes turning into macrophages, we also have them in our smooth muscle cells. Very interesting. Okay, so you can see that we have a macrophage cell that took up oxidized LDL, just like we talked about before. Now, in the process of all of that, these activated monocytes turning into macrophages will release MMP and TF. So one of the guys talked about metal proteinases. What those do is degrade collagen. So I think it was Brian. I think he posted the activity and what it does on his food discussion board. So make sure you look at that. Okay, and it also increases the amount of TF, which is a cell surface receptor that will form a complex with, these are components of the coagulation pathway, 7A, which catalyzes the conversion of factor X to active protease XA that cleaves prothrombin to thrombin. This produces a blood clot, thrombus. So the TF portion right here is directly related to the coagulation pathway that is in your atherosclerosis PowerPoint to review. Make sure you learn about the different coagulation pathways. Make sure you can draw the coagulation pathway and be able to discuss what types of drugs will inhibit respective factors or processes in that coagulation pathway. It's very common for me to ask, well, what is atherosclerosis? And you want to talk about the development of foam cells. You want to talk about the development of synthetic smooth muscle cells. And you want to talk about this prothrombotic environment. Right? And then this is one of my favorite stories because a lot of people don't think about it this way, but we're talking about fat and weight gain. And we did mention our first day talking about atherosclerosis that just because somebody is obese does not necessarily mean that they're prone to atherosclerosis. There's a lot of hormonal regulation that's involved that determines whether or not somebody is healthy or not. But in this particular scenario, we'll kind of generalize it. So as you gain weight, specifically in the visceral areas, which is the stomach, abdominal areas surrounding your visceral, which are your organs, then these adipocytes actually will begin to hypertrophy. They don't necessarily divide, they hypertrophy. As they get bigger and bigger and bigger, they become inflamed. Well, we'll call them an inflammatory endocrine organ. And when that happens, they are one of the key mediators of the inflammatory and oxidative stress process. So you can see here that these hypertrophied adipocytes increase the amount of TNF-alpha, IKKB. JNK is really upstream of the NF-κB pathway. IL-6, IL-1 beta, and IL-1 beta is actually part of the inflammasome. toll-like receptors, which are the main receptors of the inflammatory response, which means that they're going to be circulating in the blood vessels. And if they're circulating in the blood vessels, they're going to activate those monocytes. They're going to activate the endothelium, increasing the probability of monocyte binding, recruitment, and foam cell production. And I'm not going to read all of this slide to you. You can read it yourself, but this gives you an example of some of the mediators, hormones, proteins that are released from hypertrophied adipocytes that are either pro-proliferative and differentiating or inflammatory or oxidative stress. And one of the interesting ones is ACE. So we did talk about ACE long time ago as being the enzyme important for converting angiotensin 1 to angiotensin 2, and we talked about it being primarily or highly concentrated in the lungs. Well, most people think that, but really every cell in your body has the gene for ACE. Well, in this particular scenario, when these adipocytes become hypertrophied, that gene for ACE is increased. Now we're going to have more angiotensin 2. And like I think was Antonio talking about angiotensin 2, I think yesterday, it plays a huge role in inducing the inflammatory response and smooth muscle cell proliferation. But it also does other things too, like inhibit eNOS and causing vasoconstriction. Another one that is really interesting is VEGF, and one of the guys talked about VEGF, which is the vascular endothelial growth factor. It's pro-angiogenic, and we need blood vessels, but high levels of VEGF facilitate or promote or help cancer growth. We need VEGF to be present when we have ischemic coronary disease or ischemic myopathies because it helps facilitate the growth of those collateral blood vessels that help you handle the ischemia better. But when it's dysregulated, when it's too high in other areas, then we increase the probability of cancer. It also encourages insulin dysregulation. Okay, so now here's adiponectin right under VEGF. And remember I talked about obesity, and people that are obese but have healthy vascular systems actually have a higher level of adiponectin compared to leptin. So if you look at them, adiponectin is an anti-inflammatory and pro-insulin sensitivity hormone. Leptin exerts many atherogenic effects. So somebody who is obese but has really high adiponectin probably will never get atherosclerosis. Pretty interesting. Okay, so make sure you read about these different chemical mediators, proteins, enzymes, and be able to relate them to something functional, meaning a patient scenario. Okay, and keep in mind that a patient scenario is not a list of diseases. A patient scenario is patient presents like this, signs and symptoms. How did you assess them? How did you interpret that? What did you find out? And then how did you deal with that? This is an extension of that paper, and I simply just wanted to point out that this is a mouse study. When these mice are fed a high-fat diet, now this is not high-fat diet like avocado and nuts and olive oil, it's bad fat. There is obviously, particularly in week 3, an increased size of these adipocytes. You can see how they hypertrophy. A lot of people think when you get fat, your fat cells divide, but really what happens is they just get larger. So that brings up the interesting discussion about liposuction. Sometimes people think that if they get liposuction, they might reduce that fat load. Well, let's say you have 10 fat cells, and they're handling your system response to help maintain homeostasis. Fat cells are really important for that. If you take out 5 of them, now you only have 5 cells to manage that load, those 5 cells are more likely to develop hypertrophy. So getting liposuction can actually make you sicker, by increasing the probability of hypertrophied adipocytes to become inflammatory endocrine cells. Pretty interesting. Okay, and then we got to talk about the liver and metabolic syndrome. Like we mentioned in the first part of discussing atherosclerosis, there's a lot of young people that have metabolic syndrome, people who are 12, 13, 14 years old, and we're beginning to understand that that's highly attributable to epigenetic regulation. But whether or not somebody is overweight, whether or not somebody actually has vascular disease, if the liver, the main organ for fat metabolism, is experiencing dysregulation, pathology, or disease, you can see from this diagram that it's going to begin to increase the secretion of PA1, which is going to be prothrombotic, CRP, which is our marker of inflammation, high triglycerides, and low HDL. And HDL is important. We'll talk about that in a minute. It's potentially going to increase the amount of glucose uptake into adipocytes. It's going to decrease adiponectin. And remember, adiponectin was important for anti-inflammatory mechanisms. It's going to increase fatty acid, free fatty acid. And all of these can result in metabolic syndrome, or metabolic syndrome can result in those. Which came first, chicken or the egg, is something we're still trying to work out. So it's not uncommon to be able to recognize the presence of fatty liver in people that have a lot of visceral adiposity. And that increased liver fat is going to scream inflammatory oxidative stress liver, which is going to begin to release a lot of chemicals, a lot of hormones, a lot of inflammatory mediators that ultimately are going to result in endothelial vascular dysfunction. So, liver disease causes atherosclerosis. Now, this is part of this paper, and I just wanted to point out a couple things because we have a tendency to look at SGPT, etc., to determine whether or not somebody has liver dysfunction. And as you can see at the top, it says ALKT or SGPT, which are the biomarkers for liver function, does not indicate steatosis, which means fatty liver. So you might have a patient that has completely normal liver enzymes and still have fatty liver. So looking into how you can assess for the presence of fatty liver is a really good, maybe extra credit question. Okay, but the things that they did see that were correlated to fatty liver, as you can see in the bottom right-hand corner, is C-peptide. This is CRP. And insulin, hyperinsulinemia. Very, very interesting. So it wasn't the liver enzymes that were correlated to fatty liver. It was the insulin level and the CRP levels. I wonder what else. And of course, waist circumference. You can see that upper left-hand corner, panel A. Okay, now, I said that HDL is really important. Most of you guys think of that as good cholesterol. I don't know if there's good or bad cholesterol, but here it happens to be serving as a good guy. So HDL is made in the liver and the intestine, where ApoA1, the main protein of HDL, is produced. So you noticed our animal experiments in the inflammasome story had ApoE knockout. That means we're not able to produce HDL at a normal physiological level. Okay, so HDL particles actually can remove additional cholesterol from peripheral cells. So it's produced in the liver. Okay, it goes to a peripheral cell like the endothelium, Okay. And it plays a role in removing cholesterol. So this is very important, particularly if we have a lot of oxidized LDL. And it does this by the ABCA transporter and macrophages. So you can see in point number 3 there that HDL will migrate to the endothelium and participate in processes that will cause the macrophage to, via the ABCA1 transporter, move that LDL out of the endothelium. Very interesting. ABCA transporters. Efflux of cholesterol through macrophages, initiated by HDL. Okay, and here I wrote lecithin, which is LCAT here. It is an acetyltransferase that esterifies cholesterol, and this should be so it can be transported by HDL to the liver for secretion. It's a really important enzyme. Here, CETP is an enzyme that transfers a fraction of the cholesterol on HDL to LDL, which will associate with the LDL receptor and transfer to the liver. So in this particular figure, what you should get out of it is the liver is the main organ for cholesterol biosynthesis and metabolism. It produces HDL, which will travel through the circulation to the peripheral cells like endothelium, facilitate the movement of oxidized LDL out of the endothelium through the macrophage. Okay. LCAT is important for being able to make that cholesterol be in a position or chemically modified so it can be transported to or by HDL. Okay. And then LDL, some of it's going to go out through bile and some of it's going to go back to the liver. This is another paper that I put in there, and we're really talking about alcoholic fatty liver disease versus non-alcoholic, we'll say fatty liver disease, because that's what that simply means. And if you look at table 1, I've underlined a lot of the biomarkers that indicate an inflammatory prothrombotic environment. And foam cell production. So if I was a cardio student, I would look at these different, we'll say chemicals, hormones, mediators, and understand what role they play in encouraging the development of atherosclerosis and how the liver itself, independent of all other factors, can produce these, promoting the development of atherosclerosis. And this just offers a couple, or I guess 3, let's see, 3 different therapeutic modalities or pharmacological interventions that can be used to maybe inhibit this process. Now, PPAR gamma inhibits the NFKB pathway and promotes differentiation into healthy adipocytes. It's a good lipid storage mechanism. Remember, sick adipocytes become hypertrophied and become inflammatory endocrine organs. Vitamin E might be a cofactor in interrupting the lipid peroxidation. Some of you talked about that reaction that generates free radicals from the degradation of fatty acid molecules. And UCDA decreases metabolic abnormalities, particularly in the liver, to reduce oxidative stress. Now, I was going to talk about one of these PPAR gamma agonists and its role in decreasing the development of hypertrophy, but maybe we'll save that for one of the people that are going to do hypertrophy. Okay, and this slide is really important to me because the people that published the paper on this actually worked with me in my lab. Kind of neat. SIRT2 is an enzyme that deacetylates other proteins to regulate them positively or negatively. In this particular story, we're talking about the SIRT1 eNOS axis, and you all know about eNOS now. So when we treat cells or animals with activators of SIRT1, and one of those activators is resveratrol that is found in grape skin, which is one of the reasons why people say wine is good for your heart, activates eNOS. Also, if you look over here in the middle, AMPK, my favorite gene, also activates eNOS. And when we activate eNOS through SIRT1 and through AMPK, and vice versa, there's always this cyclical regulatory mechanism. Here, it's showing that eNOS activates SIRT1, and SIRT1 also activates eNOS. AMPK activates eNOS, all of them inhibiting that oxidative stress, the inflammatory process, and prothrombotic process that causes atherosclerosis. And they do it very nicely through inhibiting NF-κB. Now, the triangle over here shows that when there is calorie restriction, exercise, or things that might be considered anti-aging, which means we're activating the proteasome. Some of you talked about that. This axis is present to increase the amount of nitric oxide. Now, of course, there's always a threshold effect for nitric oxide. If it's too high and it's not metabolized properly, then it itself can turn into a free radical or an ROS. But people who exercise regularly, not too much, not physiologically abnormally, and people who pretty much are on a calorie restrictive diet, which means you're not eating all the calories that the FDA recognizes or encourages you to do so, you're eating to live, then you have this triangle or this axis activated chronically, and it produces an anti-aging state. Now, I'm going to leave this for Raiden. Okay, Raiden is going to talk about angina, but he's specifically going to be talking about the number or the prevalence of people presenting with not classical angina, not presenting with ST segment changes in an ECG, that are having a myocardial infarction, who are missed for a cardiac workup because they don't present like they should, or what we expect them to. So we're not measuring troponin levels on those people, which is the hallmark of myocardial infarction nowadays. We're missing them. They're going home and they're having heart attacks, or they're having a heart attack that's maybe not so obvious, and we do an echo 5 years later, we recognize akinesis on the echo, meaning they had a myocardial infarction. So Raiden's going to talk about that. I'm really excited about it. But in the meantime, if I were you guys, I would read this review because it talks about a lot of the chemicals, mediators, and hormones that we just discussed, and their role in producing the atherosclerotic state. Also talks about diagnosis and risk stratification. Okay, so this is one of the problems that we have. We use this information to determine whether or not somebody needs to go to a stent facility or whether they actually need to be worked up for an MI. But the problem is that not everybody will present in this way. So read through this, get an idea of what our common or classic way of thinking about the signs and symptoms of somebody presenting with a real MI, and try to find some weaknesses in this. I'd like eventually for one of the students to do a project, particularly one of the EMC students next year for their senior project, on this exact topic. How many people are presenting to an ER without the classic signs and symptoms of an MI, who are not being tested for troponin levels, having an MI, and it not being recognized? So we could do a simple experiment or a trial, recruiting a couple of hospitals or few hospitals, where they take the troponin levels of all the people admitted to the emergency room, within a certain age bracket, of course, and correlate the troponin levels with the chief complaints of why these people are coming in. And maybe we can develop a new list or algorithm for recognizing signs and symptoms of somebody having a myocardial infarction. And of course, here's our American Heart Guidelines for treating coronary artery syndromes. And I'll talk a little bit about it. Up here, it says patient presenting to the emergency room. They, of course, get a history. They do a physical examination. How complete that is, I don't know. They do a 12 lead, assuming they're presenting with signs and symptoms that indicate the need for 12 lead. And if the 12 lead shows ST segment changes that infer myocardial injury, then they'll do troponin levels. So everybody knows what troponin is. If you don't, make sure you look that up. So then we have low risk for acute coronary syndromes, intermediate risk, and high risk for acute coronary syndromes. So if we look over here, high risk for acute coronary syndromes, elevated troponin, yes, but we're missing the measurement of troponin in so many people that are actually having an MI. Newer presumed ST segment depression, which typically indicates ischemia but can be reciprocal change for injury occurring in an opposite wall, or it could just indicate a compensatory response. So if you are experiencing injury in one part of the wall, then the other parts of the wall have to compensate for that loss of contractile function or reduced contractile function. It in turn could potentially become ischemic. Recurrent ischemia despite intensive anti-ischemic therapy, well, duh. Recurrent ischemia with heart failure, high-risk findings, blah, 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 blah. Okay, so you can read that. Go over to the low risk, no intermediate or high-risk features. Well, that means that we are looking at our high risk and we're missing those features. Less than 10 minutes of rest pain. Not all people have chest pain. Not all people have chest pain. Risk factors for coronary artery disease. I don't even know what that means. What does that mean? Maybe somebody can respond to that. Non-diagnostic 12-lead ECG. Non-elevated cardiac biomarkers. That's probably the most accurate, we'll say, component of that list. Age less than 70. Now, we know that's not very accurate either. So this is the way we are assessing and categorizing patients that come to the emergency room to determine whether or not we should work them up for an MI. The most important factor there is our troponin level. The problem is we're missing the measurement of troponin when people are not presenting with what we think they should when they're having an MI. Maybe I'll share some case studies with you. Some of my patients in the past later who did not present at all like they were having a myocardial infarction, and they did. And they actually died because we missed that. Okay, if we go down here, you see early conservative management versus early invasive treatments. So make sure you know what these drugs are. We've talked about them a little bit and why we would be using them for our respective patients. Okay, and then here's a case study. And I want to talk about this case too because it's very similar to one of them that we experienced a long time ago. And what this woman actually wound up experiencing was an occlusion of her coronary artery. It wasn't due to Prinzmetal's angina. It was due to atherosclerotic lesion. But I put this in here just to remind us of what Prinzmetal's angina is. A different case that is not presented here was a 42-year-old woman who had gone to the emergency room because she was feeling chronically fatigued and she just couldn't do her work. She was so tired all the time. She was depressed all the time. Her blood pressure was low. She was nervous. She had some anxiety, and they worked her up. She was completely clean across the board. They sent her home. She had a massive coronary artery spasm, and she died. So she had Prinzmetal's angina. And you can see here in the top panel that the blood vessel is constricted, and it's right next to the box that says region of occlusion. That should say occlusion. What they did in this particular patient, this is not my patient, but this is the case study from which I found this picture, they injected nitroglycerin directly into her artery. And you can see the vasodilatory effects. So how does nitroglycerin cause vasodilation? You all should know that by now. Okay. But if we go back to the left side and look at the words, it's really important to remember that an infarction, the process of infarction is a continuum, isn't something that just happens right now. And therefore, recognizing early signs is really important for decreasing the morbidity and mortality in your respective patients. And we're going to talk about that a little bit. Also listed down there are the most common reasons why somebody experiences myocardial infarction. Coronary artery occlusion by clot, we talked about that already. Severe vasospasm like Prinzmetal's. Extreme narrowing or occlusion of the artery due to atherosclerosis. Okay, and this is just a picture of the LED with a nice big clot. You can see it there, which is the reason why we have this picture. Now, when injury is going to occur, or we'll say infarction is going to occur, there's always an initial ischemic scenario. If that ischemia is not resolved, then the area will experience injury. Injury is still reversible, but the tissue, like ischemic tissue, does not contract as well, and it's more irritable. There's irregular automaticity in there, so they're more prone to dysrhythmias, which is one of the reasons why we like to give beta blockers to them. If those are not resolved, then tissue becomes infarcted. That's necrosis, and it's not going to be reversed. But there are some stem cell studies out there. Forgot to post that. I'll do that when this is over. There are some stem cell studies out there that are proving to potentially be beneficial to people that need a new heart tissue. Now, I just want to comment a little bit about this concept of ischemia. You can actually initiate an ischemic event in your patient even if they don't have vasospasm or atherosclerotic lesions, simply by increasing the myocardial workload, the demand for oxygen, the increase in metabolic rate, without ensuring that the perfusion reaching that tissue and or oxygen to that tissue is adequate to handle that load. And we do this in ICU on our patients all the time. We don't even pay attention to it. Okay, and I'm going to pass this. You guys can read through this. You have this on your canvas, but injury essentially means that we have damaged tissue. We waited too long, we didn't recognize early signs, and now we're experiencing injury. Now, when tissue experiences injury, it's going to take one of two paths. There's probably more than that, but this is what we'll focus on for now. So we experience myocardial injury, reversible cell injury. Either that cell is going to die or it's going to adapt to that ischemic environment so it can be more efficient. And efficient here means that it can function with less energy, less perfusion, less oxygen than it would normally require. And that adapted cell type is going to be what you guys would consider myopathies and sometimes hypertrophies. So it's important to be able to recognize ischemia, injury, infarction, where it is, the extent, and the duration. And I'm going to go past this. You guys can go ahead and read this, but I want to get to the case study so we can point out actually what these waveform changes look like. Okay, so the first change, the acute change, is going to be a tall T wave. This is something that a lot of people don't pay attention to. And the T wave is going to be more symmetric. Remember that the T wave is asymmetric, with the latter third being higher or taller than the front 2/3. The T wave can become more pointed, and we call this the hyperacute phase, and it happens in the first few minutes. But how often are you respiratory therapists actually looking at the monitor and recognizing any trending in the morphology of the T wave? Probably never, but you should think about that, because when you're in the process of weaning a patient, you could be inducing an ischemic event because you're increasing myocardial workload, but the patient might be on drugs that inhibit the cardiovascular system or the sympathetic nervous system to compensate for that increase in load. And therefore, you can induce ischemia, which can turn injury. And it might present just like this with a tall T wave that you could recognize if you pay attention. Okay, so this is a 54-year-old African American female, excuse me, who works out regularly. She's got no history of hypertension, no history of diabetes, no high cholesterol. She doesn't smoke. She has no significant family history of coronary artery disease. And she presented with one episode of chest pain. The discomfort was of a postprandial onset, that means after eating, and it felt like tightness, but it was intermittent. She did not have any accompanying nausea or diaphoresis. She stated that it felt like an upper GI discomfort, but she was pain-free on arrival to the emergency room. Her heart rate was 71, blood pressure 131/70, breathing rate 18. She didn't appear to be in any distress. Upon physical examination, she had normal JVP, jugular venous pressure. We'll say distension. She had normal S1 and S2 and no S3 or S4. Her lungs were clear. But here's her 12 lead. So what do we notice here? Well, I like to start with each wall. So I'm going to look at the lateral wall first. I see in lead 1, AVL, V5, and V6. Lead 1, let's see here, looks like we might have about 1 small box or 1 millimeter of ST segment depression. That typically indicates ischemia. I'm going to look at AVL, and we've got a strange looking Curis complex there. But it looks like our T wave is inverted, which can also indicate ischemia. I'm going to look at V5, and V5 looks okay. V6 looks like there might be about 1 small box of ST segment depression. That's the lateral wall. So maybe we've got a lateral ischemic pattern. Then I'm going to look at the inferior wall. That's 2, 3, and AVF. It looks like my lead 2 is okay. I kind of have a deep S wave, though. That's not normal in lead 2. In lead 3, it looks like we have a small R and a big S. That's not normal in lead 3. So this tells us that we've got some access issues. This tells us something's going on. Let's see. Does it look like we have an ST segment change? Maybe half a box. So we'll watch it. AVF. Again, we've got a small R, big S, not normal in AVF. So that tells us there's something going on there. Then let's look at our septal wall. And looks like we've got ST segment elevation by about 1 millimeter. Then we go to V2, and there we've got our tall T wave. It looks more symmetrical, and it's kind of pointy. And we've got ST segment elevation by probably 3 boxes. So here we can see that we have a septal injury pattern because we have 2 leads looking at the same wall with ST segment elevation by at least 1 millimeter. In V3, we're looking at our RS, and it should be biphasic here. And it looks like our T wave is symmetric, which it shouldn't be. It's kind of tall, which it shouldn't be. And we have ST segment elevation by about 1 box. We go to V4, we've got kind of a deep S wave there, but it doesn't seem that we have any ST segment changes at this point. T wave starts to look a little symmetric though. So we can't really say anything about the anterior wall at this point. But keep in mind, this lady is pretty much asymptomatic. She said had one bout of chest pain that seems to be gastric in nature. So the second change that we'll look for when somebody's experiencing an injury pattern, first change was remember that spiked T wave, is an inverted or flattened T wave. So typically when we see the T wave do this, we think ischemia. Okay, so this T wave is going to begin to invert and or flatten. And then over time, what's going to happen is that ST segment is going to raise. And you can see that in the box that's in the lower right-hand corner. So when we're looking for ST segment changes, we're looking specifically at the J point. And most of you know this because most of you, I've gone over this with you or Lindsay has. So we're looking for that J point, which is the point at which the R, or if we're looking at an S wave, is trying to turn into that isoelectric line, the point at which it starts to go to the right. You want to find that J point and move 2 small boxes to the right. That is your point. So I would put a dot on the slope of the initiation of the T wave, and then I would draw a line from my isoelectric line all the way across and determine how far up that J point 2 boxes to the right is. In this particular scenario, it looks like it's about 1.5 boxes high. Okay, carrying on with our case study. Her admission cardiac markers were slightly elevated. Her CPK was 159. I would look these up if you don't know what they are. Her CKMB was 2 nanograms per milliliter, and her troponin was 0.6 nanograms per milliliter. Excuse me. She experienced repeated episodes of postprandial chest discomfort over the next 24 hours. Now, this is weird, right? Why are they waiting 24 hours to do a workup on her when she clearly had ST segment changes? I don't know. With some evidence of ST segment changes in the precordial leads, with CPK continuing to trend down. And here's a follow-up ECG. So I'm going to do the same thing. I'm going to look at the lateral wall. Lead 1 looks okay today. AVL looks okay, but the configuration of her Curious complex is a little strange, and her T wave's kind of flat. V5, ST segment depression. V6, ST segment depression. So we continue to have a lateral ischemic pattern. Going to the inferior wall, lead 2, 3, and AVF. Looks like I have a deep S wave here, biphasic, and lead 2, that's not normal, with ST segment depression. Ooh, look at this P wave right here. Looks like it's trying to have that M configuration. The dip has to be at least 1 box in width for it to be significant for left atrial hypertrophy. I'm going to look at lead 2, and again, we still have that RS. That's not normal in lead 2, but it doesn't look like we have any ST segment elevation or depression here. AVF, again, we still have that RS, and our ST segment seems to be baseline. So I can't say much about the inferior wall as having ST depression because I only see it in lead 2. But I can say that the morphology of these Curious complexes in the inferior wall is telling me there's something wrong. In V1, we've got ST segment elevation, and it looks like we've got a biphasic P wave. Can you all see that there? And an inverted T wave. In V2, let's see, do we have ST elevation? A little bit difficult to see because we've got that wandering baseline. But one thing we do have is a biphasic Curious complex, and that is not normal there. It should be completely downwardly deflected. So that's telling you there's something not right. In V3, we've got ST segment elevation in V3, which we didn't have in the previous one. And in V4, we've got ST segment. It might be depression. It might be by 1 box. So we can't really say absolutely that we have an injury pattern in the septal or anterior wall, because remember, we have to see ST segment elevation in 2 contiguous leads to say that. Now, that doesn't mean that it's not happening. And also keep in mind that when you're looking at a 12 lead, you're only looking at 12 leads. You're not looking at the majority of the heart. You're only seeing a small picture of what's going on. Okay, so this point here is just to help you remember that ST segment elevation does not necessarily mean injury or infarction. It simply indicates that the process of repolarization is altered from what typically gives us our pretty ST segment characteristic. Okay. But when in doubt, treat it like an MI because you're less likely to do harm or miss something that could have been treated and it wasn't treated and resulted in a greater morbidity or mortality of our patient. Okay, and here's just some examples of things that can cause ST segment elevation. I'm not going to go through them. You guys can read that yourself. Okay, and then the third change, and back when I first started teaching this, they would say, well, when there is a deep Q wave, deep or wide Q wave, it means that there is a transmural myocardial infarction, which means that the infarction takes up the entire wall from the inside to the outside of the ventricle or wherever. And then we realized that that's not true because we started doing autopsies on people. We found some, and we didn't find some with this big, wide Q wave. But this Q wave does typically, well, I'll say almost always, nothing is always, but I'll say almost always, indicate tissue death or hypertrophy. So we'll call it a pathological Q wave if it is more than 40 milliseconds wide, that's one small box, or if it's a new Q wave, or what we need to add here, I don't know why I didn't put it in here, or if the depth of the Q wave is 1/3 or 1/4 the height of the R wave. So if you look at this deep Q wave, if we were to measure the height of the R wave, it looks like it's about 3/4 of a box. So maybe it is 4 millimeters. If we look at the depth of the Q wave, draw a line, it looks like it's taking up more than 5 small boxes, probably 8. So it's even larger than the R wave. So that calls it a pathological Q wave. And they typically stay. They typically stay there. So it's a good indication somebody might have had one in the past. Now, keep in mind, though, not everybody gets a Q wave. You can have a myocardial infarction, never present with a Q wave. Okay, so here's our lady. She underwent exercise stress. This is a real case study, by the way. This is not my patient, but it's another case study that I was able to participate in gathering information on. So anyway, she underwent exercise stress testing, which I don't know why they did this. You can obviously see on her ECG that she has problems with myocardial perfusion imaging revealing a partially reversible defect of the anteroseptal interapical wall. So you can see the arrow there pointing to the area in the blood vessel that is not receiving blood flow. So they cathed her 48 hours after admission. Can you believe that? And when they cathed her, she had 80 to 90% occlusion of the proximal LAD. So they stented her, they ballooned her, and stented her, and you can see there that the blood flow resumed after that process. They should have done this the first day. Okay, so lastly, thinking about T waves, and we mentioned this already, T wave will regain its normal contour, its shape, ideally, once perfusion has been resolved. ST segment should go back to baseline. If a Q wave developed, it will remain as evidence that an infarction occurred, but remember, it doesn't always happen. Once baseline is achieved, time of infarct cannot be determined. So that's a really important point. Okay, and this is just a picture for you to look at that helps you see and understand the change in depolarization that occurs with septal hypertrophy and how that might appear, particularly in lead 1 on an ECG. So you can see this Q wave is actually deeper than the height of the R wave, and it looks like it is 80, I don't know, maybe 100 milliseconds wide. So just watch the diagram for a minute. This should clue you in that the depolarization of the septum is most nicely depicted by the configuration of the Q wave. Okay, so that is septal hypertrophy. Remember, if you have a deep, wide Q wave, it's either due to almost always septal hypertrophy or myocardial infarction. Here's the infarction picture, lead one. Okay, so in this particular scenario, we actually wind up having more conduction of that action potential through the septum. So it's not just going down one pathway, or we'll say two bilateral pathways. It actually is going down the two bilateral pathways and then across it again, which is why you have this larger Q wave. Remember, the deeper, the wider the Q wave, the more energy required to depolarize that tissue. So in this particular scenario, we're cycling. Okay. Here's a non-significant Q wave. It's normal size, right? You guys have all seen that before. Okay. All right. One other point is the presence of a bundle branch block. Now here, I don't know why I put LBB, but I can't change it now because I'm in the middle of the presentation. So remember the two criteria for determining a bundle branch block. You have to have a P wave preceding all QRS complexes, and all QRS complexes should be greater than 1.2 seconds. I'm sorry, 0.12 seconds. That's three small boxes. And you have to measure it from the beginning of the Q wave to the end of the S wave. Some people stop prematurely if the S wave has a strange configuration. Make sure you don't do that. Some texts will say that a QRS complex greater than 0.10 seconds is potentially indicative of a bundle branch block. So the configuration of that QRS complex is due to a conduction delay. It takes more time, that's why it's wider, to depolarize the ventricles because one of the bundle branches is blocked. Now, the thing you have to keep in mind with a bundle branch block, they will almost always present with ST segment elevation. So if you're looking at a QRS complex that is tall and wide, it will almost always have ST segment depression. That doesn't mean there's ischemia, though. It could, but it doesn't always mean that. If you're looking at a QRS complex that is wide and deep, it will almost always have ST segment elevation. Doesn't necessarily mean there's an injury pattern. It could, but it doesn't necessarily mean that that's the case. So here is a picture of a left bundle branch block, and the most specific criteria for determining left bundle branch block is looking at V1, the precordial lead V1. So here we've got a kind of a biphasic P wave, a little tiny R, a really deep S wave, but if we measure that QRS complex, let's see, 1, 2, 3, 4, almost 4 boxes wide. That means it's wide. Now I would look at all of the QRS complexes, make sure they're all preceded by P waves and that they're all greater than 0.12 seconds before I say bundle branch block. Once I determine that, then I look at V1 and I say to myself, is the QRS complex predominantly downwardly deflected or upwardly deflected? If it's predominantly downwardly deflected, that means that it is a left bundle branch block. If it was predominantly upwardly deflected, that means it's a right bundle branch block. Okay, now, some of you might have heard the term bunny ears. Please don't ever use that. Some people will say, oh, if there's bunny ears in V1, then it must be a right bundle branch block. or actually, I don't even think they say V1, they'll just say bunny ears. But the caveat to that is that in a left bundle branch block, it's very common to have bunny ears in V6. So don't use that criteria. The criteria you use is P wave preceding the Curious complexes that are wide. V1 is down, left bundle branch block. V1 is up, right bundle branch block. Now, why are we talking about this? We're talking about this because if this is new or the patient does not have a history of a bundle branch block, you must treat it like an acute infarction or injury pattern. Another thing that we want to think about is the location of the right coronary artery and which parts of the heart it feeds. Now, it feeds the inferior wall, but it also feeds the right ventricular wall, which you can't see on a 12 lead. So, if you have a patient that is presenting with signs and symptoms of right heart failure, this means they've got JVD, hepatomegaly, pedal edema, and will add hypotension in the presence of an injury pattern in the inferior leads, here it's lead 2, 3, and AVF, then you need to do a right-sided ECG. And what that means is you take V4, V5, and V6 and switch it to the other side. Same anatomical positions. Redo the 12 lead, write on the 12 lead V4R, V5R, V56, and see if you have ST segment elevation in those leads. If you do, that means you have a right ventricular MI occurring. So in this particular scenario, if we interpret the whole thing, lead 1 looks like we've got ST segment depression. This is our lateral lead. I'm looking at the lateral wall. AVL got some pretty significant ST segment depression. V5, ST segment elevation. V6, maybe there is some elevation. So here we definitely have a lateral injury pattern because we have at least 2 leads that are showing ST segment elevation at least 1 millimeter high. Go back to my inferior wall, ST segment elevation. Ooh, lead 2. Look at this Q wave. You guys see this lead 3. Look at the Q wave. So we've got a Q wave, and we also have ST segment elevation. AVF, ST segment elevation. So we've definitely got an injury pattern occurring in the inferior wall. Let's go up to our V1. Oh, look at this. We have a upwardly deflected V1. That's not good. It doesn't necessarily mean that we have right bundle branch block because our Curious complexes are skinny, right? But it might mean that we have right ventricular hypertrophy. It's very possible. Okay, then we look at V2 and we've got severe ST segment depression and a super tall R wave. We want to think about that too. I'll talk about that in a second. V3, kind of hard to tell, but one thing we can tell for sure is that we don't have our biphasic V3 like we're supposed to. That tells you there's something wrong. Or you guys just put the leads wrong on. That happens. Most people don't put the leads on correctly anyway, so most ECGs aren't interpreted correctly. V4, we've lost our biphasic. We're supposed to have biphasic there. Can't really tell ST segment changes because of the wandering baseline. V5, got ST segment elevation. Oh, I already talked about that. Forget about it. So for our V2 and our V1, V2, V3, V4, we can't really say that we have an anterior or septal injury or ischemic pattern because we don't have anything consistent. But we can say that our R wave progression, that means the configuration of our Curious complexes in those leads is not normal. So I talked about signs and symptoms of right heart failure in the presence of ST segment elevation in the inferior leads, indicating need for a right-sided ECG to rule out right ventricular MI. That's really important because right ventricular MIs will be treated with fluids because that ventricle is very, very fluid volume dependent. If it's just a left ventricular MI, we're not going to do that because we're worried about pulmonary edema, right? Make sure you study this. Make sure you look this stuff up. But the other thing we might want to think about is if we have a posterior MI occurring, what we're going to see is an R wave that's tall, which is not supposed to be in V1, or greater than the S wave. In this particular scenario, V1 has a QR. There's no S. That's not normal. And then V2 has a really tall R wave, and V3 has a really tall R wave. So if in V1, V2, and V3 we have tall R waves and severe or extreme ST segment depression, then we'll do a posterior ECG because that would indicate that we're seeing reciprocal ST segment depression to ST segment elevation posteriorly. So those are just a few things to think about when we're interpreting these 12 leads and trying to determine whether or not somebody has ST segment elevation, depression, ischemia, injury, whatnot, in walls that we can't see with a typical 12 lead. Okay, and that is it. So please review this PowerPoint. If you have any questions, feel free to send me an email. We will not have class on Thursday because I have a meeting that I have to attend. It starts at 8 and I believe it gets over at 11 or 12. But you have the presentation and I will post some more information on Blackboard about the other projects, and I will see you not this Thursday, but the next Thursday.